And for the last presentation, before we get to the Q&A, we do have my colleague, Dr. Rafael Sanchez-Salas, for focal therapy, intermediate risk prostate cancer. Is it the future or of the sweet spot?
Well, thank you very much for the opportunity. We're going to address how focal therapy will be developed or is being developed for the future, my disclosures. And this is focal therapy. It's a treatment process. It's a process like any process you can see in a cooperative approach. It's based on risk assessment that it starts at the clinic when you do the consultations, planify, imaging, MRI, proceed with treatment, and obviously evaluation of risk continues when you do the follow-up of these patients. When you look at the PROTECT, you remember the PROTECT trial, the 15-year outcomes, you see the difference between active monitoring, not active surveillance, but active monitoring, prostatectomy and radiotherapy were pretty similar in the study that shows that although the results were similar in terms of cancer control outcomes, when you look at the red line, you see how surgery does not perform that well in terms of the quality of outcomes. So the radical treatments are exposing patients to a toxicity that perhaps might not be necessary. So going back to the oncological outcomes of the PROTECT study, you see that the disease-specific survival of 3% was not reached. There was not 10% cause mortality reached, but there was a 50% reduction on the metastasis in the radical treatments. This is important. At the same time, we look at the functional outcomes for radical prostatectomy, and you see that once again in the IWIM study, there's a limited improvement in the functional outcomes of those patients that received surgery and had an indication of prostate cancer. Obviously, this is an evaluation that was not confirmed before, but now today we have the phase A study is a randomized controlled trial that actually compare SBRT versus radical prostatectomy in patients with harboring low and intermediate risk prostate cancer, and the reported outcome for incontinence and sexual bother at 2 years is much better in the radiotherapy arm. At the same time, there's bowel symptoms that are presented in the radiotherapy arm. This is level 1 evidence that is telling you the results, telling you about the results of surgical treatment. The FLAME trial. The FLAME trial is radiotherapy, but it's quite interesting because it actually proved that this index lesion that is depicted by MRI, that's what we use to guide focal therapy, is actually not longer a hypothesis. It's something that works on the biology of the disease. What they did was a boost in the actual index lesion and then compare index lesion boost and global radiotherapy versus global radiotherapy alone. And at 5 years, they found a difference of 92% versus 85% respectively with no impact on toxicity. So the boost on the index lesion has a role, and this is pretty much the idea of focal therapy. The FLAME trial was re-evaluated, and when they look at the recurrences, what happened with the recurrences? This is a recent study. They evaluated the patients that actually recur, but impressively, there was no biopsy, much of biopsy information. These recurrences were evaluated, obviously, with biochemical recurrence, but also with imaging. With the latest imaging, PSMA, and what they found is that recurrences are happening at the area of the index lesion. So their plan is to eventually diminish the amount of energy, so de-escalate energy. So this is already happening in the radiotherapy field. In the location of the index lesion, we have to be very aggressive in order to obtain the good results. So if you're thinking about treatment or diagnosis, you need to think about imaging. It happens at the diagnosis, it happens for treatment planning, monitoring, and obviously for the assessment of outcomes. we started talking about the PROTECT trial. And this is an interesting evaluation they did, because they just on PSA, they evaluated which of these patients included in the PROTECT study that actually had surgery could be indicated for focal therapy. And the results are that there's around 30% of patients that could have an indicator of focal therapy just based on PSA. But this is not what we do. We don't use PSA only. We have a multivariable approach in the process to diagnose and to indicate focal therapy. Moreover, you remember one of the rationales for the focal therapy is the Bill Axelson study, or the 29 years follow-up, that is telling us that there's limited progression in patients harboring Gleason 3+4 and 4+3, which means that the assessment that was done for this study is not necessarily what we do today, because they're not even applied or applied MRI assessment for this population. So the ideal candidate for focal therapy is a completely different candidate today. This was addressed in the Falcon study that we lead with Dr. Rodriguez. And the ideal candidate is variable. Obviously, you need multiparametric MRI. You need a biopsy that includes index lesion biopsy, perilesional biopsy, and systematic approach. And the patients you could select are those patients harboring ESUB2 and ESUB3 prostate cancer. But biopsies remain a problem. There's not an ideal way to do the biopsies. It's not up for discussion today, but transcranial, transrectal deployment of multiparametric MRI is not necessarily considered a standard in the US. In Europe, it's almost mandatory. So the starting point of the process, biopsy, is not very clear. So that makes the selection of patients a little bit awkward. These are the actual results of focal therapy nowadays, with HIFU and cryoablation having being the most visited options, followed by IRE, laser, and photodynamics. In biopsy, obviously, is the cornerstone of evaluation. But do we need to do a biopsy in every patient after focal therapy? This is something up for discussion. In places like London, this is not the regular approach. And when you look at the numbers in terms of functional outcomes, these are quite different from the numbers that I showed you before in the surgical arm, in the surgical results. These patients have path-free continence that are very, very high, and the worsening of erectile dysfunction, although it happens specifically in the first 3 to 6 months after the procedure, it normally comes back to baseline. It is important to provide level 1 evidence. This is what is proposed by the FDA, the plot by Waystock, surveillance intervention versus surveillance alone, with the analysis of local progression, and as a secondary analysis including local therapy. But this study for focal therapy was already done. Dr. Hugh alluded to. This is the TUCAT study that actually was the first ever study presented for randomized control trial for active surveillance or focal therapy, and actually show a benefit in the focal therapy arm, and including the Gleason pattern that it was mentioned is an important definition for aggressiveness in the disease. Moreover, they evaluated the need for radical treatment that, once again, was less when you look at the comparison, was less for the focal therapy arm. This is important because it provides evidence, but obviously it was done in a population that doesn't apply today because it was done for 3+3 prostate cancer. So more recently, we have the series of Dr. Bianco that are showing a 50% risk at 6 years. This is with cryotherapy. Progression defined as whole gland therapy, ADT initiation, or metastasis. So there's 50% risk at 6 years is compared to the 35 to 70% that we see on active surveillance. That means that you can think that the focal therapy is changing or might be able to change the natural history of the disease. Moreover, you have a comparison. In focal therapy, there was a la carte approach, the idea of doing HIFO for the dorsolateral part of the prostate and cryo or IRE for the anterior tumors. It has been there for a long time and actually comes from an editorial comment, but this data from Dr. Rodriguez Sanchez is telling us that this is no longer the case. So the a la carte approach is something that can be done. Perhaps, but especially if you're at the beginning of your experience or you're learning how to do focal therapy. If you have enough experience and you are seasoned with the energy you use, you can go anywhere in the prostate, and we have the numbers here in the comparison of the cryotherapy approach. So the seminal question here is, can the prostate cells, regardless of whether they are tumoral or non-tumoral, on classified or ESUP 1 or ESUP 5, can they support extreme temperatures, electricity, or a DNA repair damage as we see in radiation? This is the question that needs to be addressed in the future. And perhaps now what we have is imaging. Imaging, microultrasound, or PSMA are making a difference. Microultrasound, for instance, combined with multiparametric MRI improves the detection of those tumors that actually need treatment. And this are experiences where microultrasound can even get better results than multiparametric MRI in some specific cases. Also, microultrasound improves the detection. It runs the detection of those cancers that are higher than ESUP 2, and at least 17% of patients in the German experience were picked up with microultrasound, and multiparametric MRI was not able to provide information on the tisular evaluation. On the top of that, Optimum trial. The Optimum trial is a comparison of ultrasound versus a multiparametric MRI, an excellent trial that just finished accrual. We'll probably have the actual numbers, the results soon. PSMA, everybody loves PSMA, is what is going on in prostate cancer assessment today, but we know the PSMA that's very good, that does not have very good anatomic evaluation, but when you combine PSMA plus multiparametric MRI, your assessment becomes better. That means that if you look at the SUV max, there is a correlation in the SUV max with the actual aggressiveness or the actual tissue that you can have in biopsies. This is very important because it will take us to the point in which those biopsies perhaps not be necessary. Molecular biomarkers, we did this Delphi consensus. There's no clear information. We heard that before yesterday, but there's some hints in which you can guide your decision, especially in low and intermediate risk prostate cancer, and this is something that can be useful. It is deployed in the NCC guidelines of how biomarkers and gene expression testing should be applied for a group of patients, especially those harboring some kind of risk, starting at the 3+4 prostate cancer patients, and the same for Decipher, Prolaris, or the Oncotype. So the thing is, focal therapy is like putting a grenade inside the prostate, and doing this not necessarily is giving the optimal results that we want to have. So we need to analyze what's happening in the prostate when we induce inflammation with the deployment of energy, and that perhaps combining androgen deprivation like the ENHANCE trial or the Kronos trial that are ongoing might improve the results of focal therapy without obviously creating toxicity. This something that we all would like to avoid. About radical prostatectomy versus HIFU, or like randomized controlled trials, those are difficult. We have the HANDY trial, the Edward Bacco trial in Norway, and the READY trial. The accrual is different, is difficult, and the patients are most of them declining. It's hard to get this information. So when you look at the focal therapy as a primary treatment, you go by guidelines. Normally what you need is a registry. It's the best way to go. And AUA proposes to follow those patients in a registry, and AUA is not that clear on that matter, and neither NCCN. But based on the registry information, this is what we did. In the Focal Therapy Society, we created this registry that everybody is welcome to participate, and we have at this point over 1,000 patients that will be analyzed, and our idea is to get or gather information that will be used to improve the way we do in focal therapy. More towards the future, we have the PART trial. The PART trial was initially, they did a 100 patients feasibility study. It was published in an abstract form, but now it changed. It's a randomized controlled trial. Is in England and McGill University soon, and what we will do, we'll compare radical prostatectomy versus focal therapy, including IRE and HIFU as well. So 2 energies and in the focal therapy arm. So in conclusion, what we need to do, rather than decide we do one thing or the other, is to uncover the lethal characteristics at early stage and the time of diagnosis on biopsy. We must avoid converting focal therapy into a placebo trial. Our goal, obviously, is to guide technology and not to be guided by technology, because biology is what we know. We went to school for this. And obviously, we need the courage today to go further and assess the effectiveness of focal therapy in higher risk disease and not just in the Gleason 3+4 that might also have an indication for active surveillance. Thank you very much.
Well, outstanding presentations, lots of food for thought. Where do we start? The floor is open. Any questions, comments by anybody on any of the papers presented?
Hi, Aaron Katz, a focal guy, as a disclosure.
Good, excellent.
I was really impressed by the single-port prostate surgery videos that were presented this morning. Outstanding work. 2 questions. One as a surgeon and another as a chairman of a department. As a surgeon, I was wondering, do you need to do the multi-port before you do a single-port? Do you have to have extensive multi-port experience before you do the multi-port, single-port? And then as a chair, if I'm going to buy a single-port and go to my CEO, you're saying, well, this is great because you can get patients out the same day. So they're going to ask, well, isn't that going to reduce reimbursement for your patients? Are we going to get less money? And I'm going to tell them, well, this is a very expensive robot, and it probably only has implications right now for prostate surgery, maybe a few others, maybe some other areas in urology, but not a lot. So how do I convince my CEO to buy a very expensive robot with, at this point, few indications? So those are my two questions. Thank you.
So any of the single-port presenters care to come up or get to a microphone and talk about the 2 questions? Number 1, do we need a multi-port experience prior to embarking on single-port? Question number 2, how do we justify the expense of a new robot? Let me take a stab at it. I would think, Aaron, that having experience in multi-port would be kind of important, because you're not going to be able to handle everything with a single port, or if there is an issue that needs to be addressed, to go from single port to open surgery to fix it is a big stretch. So I personally feel that having the multi-port experience to then back you up for single port would make sense. As regards from a scientific perspective, to justify from a financial or even outcomes perspective, the single port over multi, I would like to see a prospective randomized trial. That way, you can have surgeons who are good at both do it in a prospective manner and settle the question once and for all, whether it is surgeon enthusiasm, surgeon focus driving earlier discharge, or is it truly something in coalescing all the 5 incisions to one, thereby truly decreasing morbidity? I think a prospective randomized trial is needed and should be done. I mean, throwing
Yeah, I
down the
mean,
gauntlet for it.
We already are sending a good number of our patients with the multi-port. We only have multi-port right now at our hospital on Long Island at NYU, home the same day, especially the
Exactly.
cases that we do early on. And, in the day, many of those guys are going home now.
Right.
But I just don't, at this point, I think it's wonderful and the videos are great. I'm not so sure I'm seeing the rationale for buying something like this and how I would approach the CEO at the hospital.
So at the end of the day, points made by some of the speakers regarding you can go extraperitoneally with a
Yeah.
single port. I am here to tell you, you can go multi-port extraperitoneal.
Yeah.
You can go transvesical, fine. The jury's still out on that. We did some of the first transvesical prostatectomies 15 years ago. At the end of the day, I think as a field, we are beyond the look, ma, no hands, I have amazing skills and I'm going to be able to do this unique thing versus what truly addresses the biology of the field, what truly is data-driven to the extent that we can make it happen ought to be level 1 data. And yes, it is a lot of extra work, but we owe it to each other and to our patients to put in that necessary hard work. Certainly having registries and getting more patients and more surgeons in a registry format is an excellent first step, but can't stop at that because then we are a little bit preaching to the choir. We have a long line. I don't mean to hog the conversation, guys, but come on in.
Thank you, Brad Rosenberg. All excellent talks. My question's for Dr. Hahn. I also am doing some robotic simple prostatectomies. I did a lot with the anastomosis, which is very nice. Don't need CBI and that sort of thing. My concern is the possibility of patients later developing prostate cancer and how that may complicate treatment as you sort of telescope the bladder neck down into the capsule of the prostate. I noticed your patients were older. Did that sort of influence you, or are you concerned about that? And have you had any experience with patients developing prostate cancer after this surgery?
Thanks for that question. That is the concern, that the younger patients with BPH will develop prostate cancer later on. So I have thought about not doing a bladder neck reconstruction in the younger men, but I think when you think about even doing radical prostates, you can have positive margins and you would potentially radiate that field also, right? So I think for me, at least at this point, I have not had that experience just yet, but I think it is a concern in the future. So I don't have a great answer for you for that. But to answer the prior question, I taught myself how to do single port. I think it definitely did help that I was trained in multi-port in the maneuvers, learning the planes of dissection. But it is possible to teach yourself how to do it. I used every resource Intuitive had to learn this technology. And there is a lot of benefit, I think, in doing retrosurgery. I think it doesn't work for every single patient. But I think in a lot of cases, it does work very, very well. So.
Before we go to you, I'm going to follow up on the question just asked regarding, at the end of the day, it's not about the technique or the technology, it's about the patient. So for a 70, 80 gram prostate, where we did robotic simple prostatectomies forever, why would we do that now going forward? We have aquablation. We have, other whole ep, etc. But if you want a idiot-proof, press the button, knock it out of the aquablation ought to be able to take care of it beautifully. It's athermal, and even if the guy developed prostate cancer subsequently, and we've had an occasion to do some salvage prostatectomies after aquablation, 1 or 2 only, but it's pretty straightforward stuff. So the question is, for a 60, 70, 80 gram prostate, why would we do robotic simple prostatectomy in 2024 going forward?
For anything under 80, I don't do the robotic simple prostatectomy. So my indication is 80 and above. Anything below that, I will do a TURP, or if they desire higher aquablation, I will send it over to one of my colleagues to do it. So.
Thank you. Jeff Cadedo, I have just to answer Aaron's question about selling the purchase of a SP to your administration. At UT Southwestern, I am an SP user, not an SP fan. At UT Southwestern, our biggest volume is otolaryngology, ENT, and we do a very large volume of nipple-sparing mastectomies. Both operations are not accessible, in essence, with a multi-port. So our use and enthusiasm for SP is actually outside of urology. And if there's interest in other departments expanding their volumes, that's one way where I think there's actually value to SP, not just, I don't think there's a large value of SP in urology, but in other inaccessible approaches.
I think also patients are starting to take notice of single port, and some patients are actually coming in asking for a single port surgery. And, you know, I've had patients who are like, I do not want XI. So, you know, I think as this is gaining more traction and the, you know, general population is also learning about it, I think it's, you know, it's worth looking into. And I'm great.
Yep. Dr. Hahn, that's incredible. Yes, it's the new thing, right? It's what everybody's reading about. It's in the media. Believe it or not, patients do follow social media to some degree and get influenced by it. And there's been a trend going on where what we do in practice is very different than what is shown on social media. And I think that is part of the trend. But truly, I have to say that there is a learning curve, right? And actually prior lap experience gives you so much more ability to adapt to the SP robot than having multi-port experience. Because basically what you're doing is you're trying to maneuver these very close instruments, preventing collisions, being able to maneuver around them. So somebody would, especially with suturing, somebody that understands what we did with lab and is able to modify that would be easily modifiable. The biggest issue is that you just have to be persistent with it. And if we look at every SP user that started out with one case and then a couple of multi-ports and then one case and a couple, you're not going to really gain it. I think all of us that went in committing to doing majority of our cases that way with strict guidelines actually broke through the learning curve. And once you do it, it's instantaneous. You're doing tiny things that you realize that you're not doing that makes life a lot easier. Very interestingly, we did a study with residents, and we had residents that luckily had SP experience and XI experience, and residents that only had XI experience, and residents that had no experience with robots. And we had them do a simulation. We got cognitive studies. Basically, what we found out was that when they are learning, it's easier to learn both. It's easier to learn XI and SP, and your brain adapts to it. The struggle we're having is that we're doing so well with such a great machine, and now we're regressing, taking longer, getting frustrated. And in the beginning, I say, you know, I want to do this, and I can't do this. And then I realized, well, if you want to do this, you have to change the way you do it with XI to do it with SP. And once you realize that little change, you then can not only overcome the learning curve, but take advantages of the different things that this platform applies. I think it's a plus to have in your armamentarium. I don't think it's going to replace anything. For me, it was a fix to getting more block time. And I'm going to enjoy that as long as I can until more urologists and other specialties take over, and then they need to develop something else that we jump into to, again, give us kind of exclusivity on it.
So while you're at the microphone, so what's your answer to the question? Would you recommend prior multi-port prior to getting into single port, or not really?
They have to understand the steps of the procedure done through a minimal invasive approach and understand how to use the robot. I think that is enough for them to then jump into the SP. It is very unrealistic for somebody to know SP before they know XI, but I think teaching them together, if somebody is about to learn, teaching them together makes a very big benefit. But somebody that's doing open or lap and then jumping into SP, that might be big of a leap, because then they have to not only modify the use of the instrument, but also modify the approach. The thing about the SP is it's just telling you what steps to use, what steps to do during the procedure.
Couple more questions for you. So you mentioned I loved your video, loved the way you, showed some nice nuances, so full marks. your comment about lymphocytes being a real thing after extraperitoneal prostatectomy. And so, while it's not a real thing after transperitoneal prostatectomy, so how do we justify that?
So here's the issue, right? And so when we do a transperitoneal approach, it doesn't mean that we do not create lymphocytes. It's just they're not a confined space. That
Yeah, so it doesn't, it's not a clinical issue. So how do you justify it?
So what I do is you just have to be a little more careful with your lymph node dissection. And again, having done XI extraperitoneal, you have to use clips. You have to visualize those lymph vessels, especially the large ones, and control them either with bipolar or clips. An easy thing to do is either create a peritoneal rent, which is actually not my preference. I do, in the majority of cases, use 4 cc's of Eviseal, which is basically the sealant that we use in partial nephrectomies. And what that does is it blocks the lymph node channels completely. And I went from almost a 20% rate of symptomatic lymphocytes that require drainage to 0. And so, yes, there's a little more
as
cost.
you do more, they'll come back.
Yes, exactly. And so you just have to know, in the beginning when I transitioned, I kind of forgot that we get so many lymphocytes, and then I started to see them and realizing that, 1 out of 3 in the beginning we're getting, because I do an extensive node dissection. And so as a result of that, I started to be more meticulous about my node dissection and then using other ways to prevent it, because yes, the $300 that you pay for that vial is not worth a readmission with a percutaneous drainage and then the patient having that for that long. But it's more the extraperitoneal approach that does this, not the SP itself.
Yeah, and I'm not sure a 4 centimeter creating a rent in the peritoneum, it is likely to seal off very quickly.
That's why I
likely.
potentially don't, I think it does help, but I personally prefer to use a product that would seal the lymph vessels and prevent the lymphocytes.
Which also has not worked routinely for us. Heads up.
Yeah, in my experience, it's worked very well. And it has to be the Eviseal, because then you can spray it and really cover all the areas, while at the same time being very judicious with seeing the lymph vessels and cauterizing it. So I could say, probably because the majority of my patients are out of town and maybe out of state, that maybe other urologists or other physicians see them, but I am not seeing the rate at which I used to see them before.
Excellent.
Yep.
Dr. Kau, come on back up. You were at the microphone. So, yeah, so just your comments or a question?
Yes,
yeah.
Thank you. The fantastic session. I echo what you said, that, having collaboration between the focal therapy and the SIRS will be very beneficial so that we can really match our opinions. The patients will benefit from coming open-minded and look at options. There is nothing that's a switch of a button. And we need to always avoid falling into that trap. Is this better or that better? Do I cut or inoculate in a partial nephrectomy? There's nothing that is a switch. Many times it's a spectrum, and we need to come in an open-minded. When we say that we saw Dr. Han's movie, fantastic, simple prostatectomy. Why do you need it? Of course, I get patients from my HOLAP experts and in my hospital when the patient have a urethral stricture, let's say, 500-gram prostate, blood thinning, don't accept blood, lot of things that you may want to triage and custom make your approach to patients. So the more options we have for the patients, the better. Focal therapy, single port. A lot of patients, we have a tumor board for our focal therapy patients. We really try to do what is for the patient. And indeed, what you see on social media, at least as far as many of us, is what we do. It's not discrepancy. We try actually to be very transparent. We started the SPARC, Single Port Advanced Research Consortium. We have 30 academic centers, including the esteemed panel, that share data sharing agreements with us. We have 4,000 patients. We are interested in clinical outcomes. If something did not work, we will be the first to abandon it. But
how about a prospective randomized trial?
Absolutely, Dr. Gill.
Let's do it.
That will be the ultimate, but it has to mature. I mean, we've seen many examples.
After 3,000 patients, it's mature.
That's collectively.
I know.
So few centers are good enough and absolutely will take it on, but there are few centers. It cannot be yet, as a big group.
Figure it out. Well, let's do it.
Absolutely. Yeah. We will be happy to now. We have matured some of our experiences. But again, Dr. Gill, it is all this literature that's out there that you will have somebody just still struggling in the technique and they go do a randomized study. I mean, we've gone back when laparoscopy single port started and we start comparing prematurely. We were together at that time. Same here. Let's focus on what matters is that come with open-minded. If it works, build on it. If it doesn't, abandon, move to the
Agreed.
next.
A specific
Yeah.
question about transvesical.
Yeah.
Air embolism.
Yes.
Okay, and I just want to get opinion from everybody in the room. We recently had a mortality with air embolism on table during a transvesical simple prostatectomy. If you look at the literature, now we are talking specifically benign prostate, we are talking specifically simple prostatectomy versus other techniques available. In my limited review, the incidence of, and the reason I'm harping on this is because we were having a conversation with the FDA last week, and they brought it up, and we've been thinking about it already. So the incidence of air embolism, pulmonary embolism, cardiovascular mortality after aquablation, 0.02%, after laser, TURP, laser, it is about 0.2%, TURP, etc., 0.4%, and with after simple prostatectomy and the little bit of stuff that we looked at, about 2%. So that's a real concern.
I can comment on that.
Please.
So when you put percentages, we need to look at the denominator. When you say TURP 0.1% out of a million case, you can have few. Same few, if you bring them to the 100, 500 cases of SP simple, it will be 2%. So yes, things happen. We take them seriously. We see what can we do better. When we started, we had air embolus. Luckily, no mortalities. Few mortalities happened. That's very sad, as you mentioned. However, we changed pressure in the bladder has to be low. When we were doing laparoscopy together, 15 was the standard. 15 is not good, not even for laparoscopy anymore. We are under 10 of normal pressure. We eliminated subcutaneous emphysema even with that.
But even 10 is higher than the venous pressure. So all I'm trying to get to here is the path. Is there a pathophysiology? Is there an explanation? And then at least in my mind, okay, and I'm open to comments and critique here, at least in my mind, a pneumoperitoneum versus a pneumovesicum are two different things, especially for simple prostatectomy, not about radical, but simple. If it's a pneumovesicum and you have an open venous sinusoid, which will be happening as we are enucleating the prostate, the CO2 is going straight from the insufflator into the venous system. Okay, there is no diffusion of, and furthermore, the tissues are at stretch. Tissue is at stretch. The pneumovesicum stretches the bladder and also the prostate capsule. And as you know, the venous system is at a negative pressure. And 10 millimeters of mercury is more than negative. So all I'm thinking is, at least in my mind, it is a setup for potential problems. And we have to look at this seriously and really look at our data and put together some kind of a communication talking about this specific issue, because the FDA brought it up.
So we have already reviewed our registry, and the paper is in press. So it's coming up online about the complications of insufflation, not specific only to simple prostatectomy, to everything we do SP. We've not seen emboli in radical prostate transvesical, so it has to do with the big veins in a big prostate for the benign. Part of it is our anesthesiologists like to dehydrate the patients, so we changed that. We hydrate them, that increased the intravenous pressure. We work under lower normal pressure, as I mentioned. And the third thing, you don't want to keep big veins open and look at them. If that happens, we grab it and suture. And the fourth thing, we change the technique, so we keep the anterior dissection to the end, so that you don't get into the veins. So you're inside the capsule, that's not usually an issue. You cut all the adenoma, keep that bulky adenoma at 12 o'clock, and at the very end you take it. You have more space. So we're changing, we're adapting to all this. And I'll tell you personally, our first 2 cases, the only 2 cases we've had air embolus was the first case of each of my fellows doing. And then 400 cases forward, 0. We adapted immediately. We had meetings. What can we change? We changed them. 0 in my center. So there is an evolution. That should not happen. We should learn from each other. That's why these meetings are for.
Yeah,
we need to cross.
Good discussion. Yeah. Quick final question for you.
Yes, sir.
Congratulations on your transvesical radical prostatectomy.
Thank you.
You didn't show any pathology data, so talk about positive margins, talk about nodal counts, talk about PSA recurrences.
If we take the entire series, including case number 1 and 2 and so on, we have 12% positive margin. And this 12%, part of it, we think, is we make a small incision and we try to really struggle to pull it out. So recently, we start making the incision about half a centimeter bigger or adapt to how big the prostate is on the MRI. Because taking it out from this small incision, you really tear, at least the SV part and so on. So there's some iatrogenic. Dr. Benedier, who's in Florida now, was an oncology fellow with us, looked at the data and said, how many of these patients 2 years later had BCR? It was very similar to the XI. So while we have 12% positive margins, it did not affect the recurrence rate, at least in the first cases that we've done.
Yeah, early days.
Yeah.
Thank you.
Yeah, thank you, Dr.
Next.
This is a question for Dr. Han. Great presentation, and I ask as a robotic surgeon and a focal therapist. You did a very nice, your 360 reconstruction of that eversion. The question goes to bladder neck strictures or contractures after suprapubic prostatectomy, because when I started 14 years ago doing the retropubic prostatectomies for BPH, fundamentally I was doing milling and whatnot. I switched to transvesical because of time. So I don't do single port, I do multi-port, but it takes me on average about 40 minutes or less to do these procedures and very efficiently. However, that has come at a cost of more bladder neck contractures than what I saw when I was doing the millings. And I have done the reconstruction like you showed in your video so nicely. And, maybe it's anecdotal, but, I stopped doing that because I felt that those were more prone to have the strictures rather than just doing like a little V and an advancement where you can actually reach it to the urethra and leave it like that. So I would like your comments on it.
So there are some cases where, like the really large adenomas, where I can't bring the bladder neck down, and in those cases I don't. And I'll bring it down part way, and anything that's bleeding, I'll suture it. So when I try not to put so much tension that it can cause devascularization. I've been doing this for about 2+ years now. I've not had any bladder neck contractures. Granted, 10, 20 years down the line, it may come up, and I think that's where the SPARC data can, show us if we have higher rates of that. But so far, knock on wood, I have not had any issues with that.
Steve? Okay. Focal therapy guys in the room. So Dr. Hugh just walked out, Mark Empton walked out. Okay, well, I guess my question is, I think Jim Hugh made a very good point about 40% positive biopsy rate, in field or out of field in aggregate, which is obviously a concern. And so just let's talk about that, because for grade group 1, it's obviously active surveillance for the most part, but intermediate risk is the playground, is the battlefield. And let's talk about, the PROTECT trial showed that the cancer-specific mortality difference between active monitoring and surgery at 15 years was less than 1%. So, and all these are changing the way we are thinking about the disease. And just let's have a conversation about focal therapy for intermediate risk prostate cancer. What's our defense of a 40% positive biopsy rate in the total gland at 3 years, let's say? Dr. Stricker.
So mine is a comment and a question to all the members of the panel, and I suppose to the audience in general. This is a fantastic concept to have the two groups together, as you suggest. My question is, should we be developing prostate cancer specialists rather than robotic surgeons or focal therapy experts? Should there be one person you go to who has equipoise, who sits there with the patient in front of him, who has expertise in focal therapy and has expertise in robotic surgery and has expertise in MR-Linac planning, and sits there with the patient, different to the paradigm we've got now, and then he rapidly sees a failure in focal therapy and does robotic surgery, or he advises the person against focal therapy and has surgery. So do you think that this concept of having focal therapy experts and single port robotic surgery experts who don't do focal therapy is actually not in the patient interest?
Excellent point. At most centers, I mean, certainly the expert centers, tertiary quaternary centers, there are experts in both in the same department. Whether they sit together on every single patient is just the fiscal responsibilities of practice of medicine won't really allow that. But that said, all I can talk about is at our place, we have a constant communication. We take patients I take patients from my clinic to my colleagues' focal therapy aspect and vice versa. There's a free flow of patients. And yes, absolutely, I think that is essential to have the patient's individual disease status dictate what collectively we feel ought to be the treatment offered to that patient, not just try to pigeonhole into what I like to do.
And the reason I bring it up is in some places around the world, the focal therapy people will hold on to their patients for too long, and similarly, the surgeons won't allow the focal therapist to be treated. I won't mention those areas, but we're all aware of those. And that can lead to poor outcomes.
Very, very good point. And at the end of the day, it's the patient left holding the baby. Continence, if it's not good, is a big deal. ED in some men, big deal. Go ahead.
Oh, I wanted to address your question, Dr. Gale. I personally have done close to over 2,300 MRI fusion cryo procedures in the office on over 2,000 patients. So I think that it's critical to discriminate what's outfield between infield, all right? And when it comes to focal therapy, one of the concepts that we need to manage is that patient can be retreated, especially if they have outfield recurrence. And in fact, most of them will ask you to have it done. Will ask you, can you do it again, doctor? So our positive biopsy rate, depending when you cut it, is going to be anywhere between 32 and 36%, with 2/3 of them being outfield and 1/3% being infield. And for those patients, really, I think the key metric really is if we're changing our posture to a more aggressive one, whether those patients were sending for radiation or whether we're sending for surgery. Granted, in our series, the median age is 70, so the risk of dying from other causes is about 10%. And that's what that curve that Dr. Sanchez showed. And I think this is very important, which was analysis performed actually by Mike Atan. And I think that, that question is, sure, you're not going to kill all of them. But if you can render then 65%, 70% of them free from disease for 10 years, that's a significant advantage in their quality of life. Because the overall hit they get in shim scores is less than 20%. And they keep their ejaculation. So it's not about just cancer control. And this is where, like I trained at Memorial, I had to retrain my brain. It's not just every cancer cell out, it's quality of life. So it's a little bit more holistic in that view.
Well said. Open it up to comments, but just I'm going to quickly follow up your comment by saying that for intermediate risk prostate cancer, it's not just about cancer control. It is about patient morbidity, and as long as the window of cure is not compromised, certainly, since not everybody is dying from intermediate risk prostate cancer, even at 15 years, the morbidity, procedural morbidity is a big deal.
Furthermore, the actual, conversion rates between those who began as 3+3 versus those who are 3+4 is the same in our series, and that's a paper you'll probably be reviewing soon.
Rafael.
Yep. So 40% recurrence is based in a stratification that is not what we're doing now. And I definitely believe that we're doing too much biopsies. When you look at the radiotherapy experience, and we definitely need to look at what they're doing because they have more protocols than we do. They address the disease. It's the same disease. They do protocols in low risk and intermediate risk. This 40% is based on almost non-stratification that is not close to what we do. If focal therapy fails, which I certainly doubt it, on time, we're learning how to approach the patient in a way more refined way. It's not biopsy surgery. It's even the analysis starts before the biopsy. What kind of biopsy do we have to do? How are we addressing the previous negative biopsy patient? So on the top of that, if we manage to establish a symbiotic treatment in which focal therapy will address the index lesion and we tackle the prostatic microenvironment with something. I will say it could be ADT, it could be immunological treatment. That will probably make a higher success for the approach, but definitely this has to be proven in the future.
ADT has its own issues. Okay, so, but just keeping that in mind. But at the end, overall, just as an FYI, we are in conversations with the FDA currently about planning a prospective randomized trial between focal therapy and radical prostatectomy in the United States. It's never happened. And here's hoping that moves forward. In this particular instance, it is comparing aquablation, extended aquablation versus radical prostatectomy. The first 20 patients for pilot trial are done already, finished, and now a 400-person trial is in the planning, wherein the goal being to extend an athermal, near total, subtotal transurethral treatment up to the capsule. We shall see how it goes. But I feel that, fiscal responsibilities are also part of the deal. And I think that if and when the FDA approves a focal therapy treatment for prostate cancer in the United States, the day that happens, much of this debate is going to start tilting significantly.
Exactly. I think that's amazing that there will be a randomized controlled trial. I do hope that we move it into the era of real focal therapies, not an aquablation or something that we're not really thinking about using right now. We need to remember that patients want focal therapy, and we also need to remember when we have these arguments about 40%, is it in-field, is it out-of-field, is that current data, that there's a really high bar to help men live longer with radical surgery. And let's not forget the Scandinavian prostate cancer trial. A subset of men have to be young, have to live a really long time to achieve that benefit. And all of the randomized controlled trials which show parity between the different treatments over time.
Excellent point. Other questions, other comments? Otherwise, I'm going to keep rambling over here, and that doesn't help the cause at all. Come on up, Jeff. As he walks up, let me just say that I love doing surgery as much as anybody in this room, okay? And I will put my thumb down for that. That said, I'm having a real hard time now looking a patient in the eye who has GG2 or low volume GG3, but certainly GG2, and telling him, you know what, robotic prostatectomy is the best thing for you. I just have a real hard time doing that going forward. And I think introspection is needed. And the PROTECT trial, which showed 1/3 of men in the PROTECT trial at 15 years, less than 1% cancer-specific mortality difference between monitoring and surgery. We should think about that comment. Jeff.
I have a question in terms of the focal therapy and the concept of in-field recurrence only, the biopsies that are in-field, regarding the thermal therapies. And you might remember the debates we had in the early 2000s in kidney tumor ablation, the heat-based RFA at that time versus cryo. And the heat-based therapy in kidney and in all tissues causes a heat fixation, where the cells are fixed and then encapsulated in the scar, and they can sit there, and they're not viable. And so have people done viability staining of the in-field biopsies that are positive beyond H&E? Because I think that some of these are not actually viable cells. These are heat-fixated remnants cells of the ablation, which we know now, 20 years later, with microwave and/or RFA, it's not a recurrent cell. It's actually a dead, it's just a heat-fixated cell. Do we know that in prostate? Has anyone ever done that?
So your question, Jeff, once again is
Post-heat thermal ablation of a tissue, it causes heat fixation of the cells. Those cells, when you stain them with H&E, they're heat fixated. They're literally hard-boiled eggs. It's been published, and it's known in other literature as well as a urologic literature from the 2000s, where these cells, the nucleus, the cell cytoplasm, the cell membrane is intact. But when you do viability stains, and there's several of them, tunnel and ADH, they're not metabolically active. They're dead cells that are heat fixated. Unlike cryotherapy, so I can't explain a cryotherapy in-field recurrence because cryotherapy causes cell lysis. IRE causes cell lysis. So if there's a remaining cell in those two technologies, I still would want to know if they're viable cells, but I suspect they still are. But in the heat-based TULSA, HIFU, I suspect some of your cells are not viable, and you're actually fooling yourselves. And I would encourage you, if you haven't done it, to look at that.
I think that's an excellent point, and also the beauty of these two societies combining, getting experience from Dr. Kadedu. I always wondered the same, these positive biopsies that are positive on histology, but actually not really viable cancers. We just say, oh, it's a failure because on my biopsy, MRI was negative, PSMA PET was negative, but I still got a biopsy just because I want to follow protocols. And then I wonder, sitting with the patient, oh, you still have a 3+4 disease. It's an excellent point, probably an idea for us to look into it. I think that's...
And so, the same thing goes with radiation. I can only speak to this as kidney. I can't talk about it as prostate, but, in SBRT for kidney cancer, that causes cell arrest. It doesn't cause cell lysis, cell death. And those tumors go into cell arrest, and they just sit there. We published just last year, and our disease-free in terms of recurrence is better than surgery almost, 95%, as good as surgery. So I just wonder that we need to understand the biology of the therapy we're applying. Surgery is obvious, but you should look at this in the prostate.
If I can, so I'm with one of the manufacturers, but in the treat and resect studies that were done at Sunnybrook and at the University of Turku in Finland, we're using the TULSA device, they did observe that heat fixation phenomenon. And so they did publish on that in a couple journals.
Final question, comment.
Yeah, hi, thank you. So I'm Mike Schwartz. I'm from Northwell in Long Island, and I'm somebody who does both radical prostatectomy and focal therapy, about a half-half split. To answer Jeff's question, I think about some of the sort of quote infield recurrences. What we have to remember when we're doing our transperineal biopsies, for example, when sampling the target lesion, I think the places where we see our recurrences in the world of cryo tend to be at the margins or at the end of the targeted area. And when we're taking the biopsies, I think a lot of what we're getting is, quote, infield recurrences. Like, we're taking a longitudinal needle sample, and so is that needle going beyond the targeted lesion or proximal to it in that approach? But maybe if we were to be taking biopsies that we can orient for the pathologist to look at to give us some insight into that, or do we need to be taking biopsies differently post-treatment, or thinking about using different selection tools when we're trying to treat these patients, the AI assistants, et cetera, with MR to really help plan our margins better may really help us with this. But I think to the question Jeff was asking about how do we explain cryo, that may be a way to explain the cryo-positive, quote, infield recurrences. Are we just sampling the margins in front or behind the target?
Excellent. We'll leave it at that. I personally learned a lot from this session, and even if we don't get clear answers, at least we start thinking about stuff. Thank you very much to the organizers. Great job.